All right, welcome back to The Explainer, everyone. Today, we're diving headfirst into the high-stakes, incredibly fast-paced world of pediatric clinical triage. We'll be using actual board exam materials to really master rapid pattern recognition because, in pediatric emergencies, separating the critical signals from the background noise isn't just about passing a test, it is quite literally a matter of life and death.
Okay, let's dive right into this. On our clinical rounds today, we're tackling pediatric GI emergencies, urologic anomalies and UTIs, recognizing pediatric malignancies, and finally, essential clinical ethics. Let's get to it.
Section 1. Pediatric GI Emergencies.
All right, put yourself in the shoes of the attending physician for a second. Imagine a panicked parent rushing in with their 3-week-old boy. The history is super clear, right? He is forcefully vomiting after every single meal. And here's the kicker, he immediately tries to eat again right after. He's lethargic, his fontanelles are sunken, and his skin turgor is noticeably decreased. So, what's your immediate diagnosis?
Here's the absolute diagnostic dividing line you need to look for: the presence of bile. That's your ultimate signal versus noise indicator. This poor, hungry, dehydrated little guy has non-bilious projectile vomiting, and that is the classic textbook hallmark of pyloric stenosis. If we ran labs right now, we'd see a hypochloremic, hypokalemic metabolic alkalosis, just because he's losing massive amounts of stomach acid. A barium study? That's going to show a narrowed pyloric channel, what we call the string sign. But if that emesis was bilious, well then we'd be looking down a completely different and often immediately devastating pathway. Things like duodenal atresia or necrotizing enterocolitis.
So how exactly do we treat pyloric stenosis? It's a very strict 3-step execution pathway. Step 1, keep the patient NPO, nothing by mouth. Step 2, get IV access to correct that severe dehydration and those really dangerous electrolyte imbalances. And listen, this is an absolutely crucial point. A lot of folks want to rush straight to the operating room, but correcting the fluid and acid-base imbalance must absolutely precede Step 3. And Step 3, of course, is the definitive surgical correction, the pyloromyotomy.
Now, while we're still hanging out in the GI ward, we need to rapid fire through 2 other critical emergencies. First up, intussusception. You want to watch for colicky abdominal pain in a toddler, a sausage-shaped mass in the right upper quadrant, and those infamous current jelly stools. The definitive fix here, an air insufflation enema. Second is necrotizing enterocolitis, or NEC. This one almost exclusively hits premature infants. So if you see a preemie with bloody stools, severe lethargy, and an X-ray showing pneumatosis intestinalis, which is literally air trapped right within the bowel wall, that is completely pathognomonic for NEC.
Moving on to Section 2, urologic anomalies and UTIs. Okay, here's a really common pediatric urology dilemma that's absolutely going to test your procedural discipline. You've got a child, somewhere between 2 and 24 months old, presenting with unexplained recurrent urinary tract infections. Now, recurrent UTIs are no joke. They significantly increase the risk for long-term renal scarring and even chronic kidney disease down the line. So, what is the exact correct imaging sequence you have to order to catch the underlying cause? You really have to adhere to a strict step-by-step algorithm here. First things first, always treat the active UTI with antibiotics. Second, perform a renal ultrasound to check for anatomical blockages or hydronephrosis. And, a classic dumb mistake here is skipping the ultrasound and just jumping straight to Step 3. Don't do that. You only order a VCG, avoiding cystourethrogram, if that initial ultrasound actually shows abnormalities, scarring, or if you strongly suspect high-grade reflux.
Let's take a look at why this algorithm actually exists in practice. Imagine a 2-year-old girl with recurrent UTIs. Her ultrasound showed no obstruction, but a VCUG revealed grade 2 vesicoureteral reflux, or VUR. Now, VUR is basically an incomplete closure of the vesicoureteral junction. And that anatomical flaw is essentially a two-way street, allowing urine and any bacteria swimming in it to flow backward from the bladder straight up into the ureters and kidneys. The definitive execution for preventing future UTIs and renal scarring for this specific patient? That's going to be long-term oral antibiotic prophylaxis. But we really need to contrast VUR with a major structural emergency, posterior urethral valves, or PUV. When you're looking at a newborn male with bilateral hydronephrosis, you're usually facing what we call the 50-50 dilemma. Is it PUV or is it uretero-pelvic junction, UPJ, obstruction? Well, here is your tipping point. PUV happens exclusively in males and causes a functional obstruction of the posterior urethra. This leads to bilateral hydronephrosis and a really thick-walled distended bladder. UPJ, on the other hand, is the most common cause of pediatric hydronephrosis, but it's typically unilateral, so the bladder stays totally normal in caliber.
Another high-signal indicator for PUV is a history of oligohydramnios, just due to decreased fetal urine output. A really dumb mistake here? Trying to manage a neonate with suspected PUV and a skyrocketing creatinine with simple observation? Absolutely not. PUV is a leading cause of chronic kidney disease in kids. The correct execution is immediate bladder decompression with a feeding tube or suprapubic catheter, followed by surgical ablation of the valves.
All right, Section 3, Recognizing Pediatric Malignancies.
Let's set up a highly dramatic presentation that absolutely demands immediate clinical recognition. Picture a 2-year-old girl being brought in. She's really struggling to walk because of truncal ataxia. Her eyes are making these rapid, chaotic, darting movements, a condition we clinically call opsoclonus myoclonus. And on physical exam, you palpate a firm, smooth mass right over her right upper quadrant. So what underlying malignancy is practically screaming at you right now?
If you guessed neuroblastoma, you hit the nail on the head. Those chaotic eye and limb movements, we often call those dancing eyes and dancing feet. It's a paraneoplastic syndrome that acts as a massive, blinking red flag for neuroblastoma, which is the most common tumor of the adrenal gland in children. On a molecular level, it's actually driven by the overamplification of the MYCN oncogene, and that results in a huge spike of catecholamines in the blood and urine.
Now you've got to create a really clear mental dividing line between neuroblastoma and the other major pediatric abdominal mass, Wilms tumor or nephroblastoma. Making a critical diagnostic mix-up here is incredibly dangerous. So remember, neuroblastoma often arises from sympathetic nervous tissue, like the adrenal medulla, and characteristically, it crosses the body's midline. Wilms tumor, on the flip side, is a renal malignancy that typically presents as a massive, unilateral flank mass, and it's very often associated with Beckwith-Wiedemann syndrome.
Take a look at the cellular pattern on this biopsy. If you see a 6-year-old boy coming in with severe leg pain, and an X-ray shows a poorly defined lytic lesion in the tibia with an elevated periosteum, that classic onion skin appearance, and then a biopsy reveals these multiple small round blue cells, well, that definitively points to Ewing sarcoma. It's a primary bone malignancy derived from bone mesenchymal precursors, and getting a rapid, accurate diagnosis here is absolutely essential for staging and treatment.
Okay, moving to our final round, Section 4, Essential Clinical Ethics.
Let's take a look at an uncomfortable that honestly incredibly common adolescent encounter. You have a 15-year-old girl in your office for recurrent UTIs. Her mother steps out of the room for a moment. The patient immediately avoids eye contact, looks at you and asks, "If I answer these questions about my sexual history, will you promise not to tell my mom?" So, what is your exact, correct ethical response here?
The absolutely crucial point here is balancing honesty with your duty as a physician. You just cannot make a blanket promise of absolute secrecy. The correct response is to carefully, gently inform the patient that her information will be kept private, but it has to be shared if her safety or the safety of others is at risk. It's a really tough balance. You're weighing the absolute obligation to protect a minor's confidentiality to foster trust against your overriding, legally mandated duty to investigate potential sexual abuse or any life-threatening harm.
Let's quickly summarize the definitive list of when adolescent confidentiality literally must be broken. Think of it as the safety first mandate. You must break confidentiality in cases of child abuse or suspected abuse, suicidality, homicidal ideation, certain reportable sexually transmitted infections, and, depending on specific state laws of course, when consenting to an abortion. Knowing these exceptions cold is just as important as knowing your antibiotic dosages, for sure. I want to leave you with this really provocative final thought from our sources. Imagine a 5-year-old with hydrocephalus who urgently needs a life-saving ventricular shunt revision. Her father consents to the surgery, but her mother completely refuses, arguing the child has been through enough. As the attending physician, you now have a parental disagreement that directly threatens a child's life. So what do? Do you operate immediately anyway? Do you call Child Protective Services? Do you scramble to get an emergency court order? I want you to really chew on that scenario, because navigating that exact kind of complex, high-stakes conflict, that is what truly defines clinical leadership. Thank you so much for joining me on this explainer, and keep that focused learning going.